Request Dr. Deepthi Iyer with an interesting and important tool, ASOCT, and how it's going to help all of us.
Good morning all. I would like to thank AIOS for giving me this opportunity. So today I'll be just telling how an ASOCT is used as a diagnostic tool to see the unseen in a routine clinical practice, basically when you're practicing a general ophthalmologist, apart from being a cornea specialist. So as we all know, ASOCT is it just slices up our ocular structures into thin sections so that we can see more detailed structures or more pathological, pick up some pathology in it. So there are, so widely it has evolved from being time domain to spectral domain to swept source, and time domain is something where the resolution was not that great, and spectral domain where the resolution was great but the depth was not enough. And with the swept source it has advantage of better resolution and better depth, where at a single scan you can see everything from the tear film to the anterior hyaloid, and then you can also see limbus to limbus. So what an ASOCT gives? It gives us a line scan, which I'll be basically telling today, and in addition to it, it will give us corneal pachymetry, epithelial thickness, stromal thickness maps, and also corneal dioptric power. So before going to the abnormal thing, how does a normal cornea look in an ASOCT? First, what we see is a thin hyperreflective layer of a tear film, following which what we see is a hyporeflective layer of epithelium, a moderately hyperreflective layer of Bowman's membrane, a varying hyporeflectivity of stromal layer, and a hyperreflectivity layer of Descemet's endothelial complex. So it helps us in diagnosing various ocular surface lesion. So this clinical picture, we can see there is a conjunctival lesion extending onto the cornea, which is a gelatinous lesion, and there is a rose Bengal stain positive. So on doing an ASOCT, what we could find is there is an abrupt transition from normal to abnormal epithelium. There is an increased epithelial reflectivity, and there is a clear demarcation line between the normal and abnormal epithelium, and it has not ruptured your Bowman's membrane. So this is a case of OSSN, and it gives us an optical biopsy. Not only it helps us in diagnosis, it also helps in monitoring the resolution. So this case, when we started on 5FU, the clinical picture you can see with just one cycle, the lesion is almost not there in the clinical picture, but then when you do an ASOCT, but there is still some hyperreflectivity there. So it is not gone, the normal epithelium structure is still not come. So on repeating the cycle of 5FU for one more week, and what we could find is there is a normal hyporeflectivity layer of epithelium or normalization of epithelium, which clearly indicates a resolution of this lesion. So this is another case where there is a pigmented pigmented ocular surface lesions mimicking an OSSN. When you do an ASOCT, what you could see is there are some clear cystic spaces inside the lesion, which indicates it's not an OSSN, but it's just in conjunctival melanosis. So you could safely plan a procedure what you would be planning. In this case, this cataract surgery was done. When you have to plan surgical depth, where in case of a granular dystrophy, when there are deposits present all over the cornea, if it is just present in first 150 micron layer, you could just do away with the PTK. If it is in a deeper layer, then you need to plan an additional lamella procedure. So in case of, this is a case of a chemical injury with pannus, dense pannus where the stromal, underlying stroma cannot be made out, what is the haze and all. But then when you do an ASOCT, we could make out that when you dissect the pannus, there is a sufficient layer of underlying stroma, and then you could not, you can just get away with doing a pannus and no additional lamella procedure is required. So this is a case which it also helps us to decide which type of procedure to do. So it's a case of PBK, pseudophakic bullous keratopathy with corneal scarring, and AC details can't be seen, wherein the iris shadow, nothing can be seen in this case with vitreous in AC and all. So with this case, we would just, at first seeing this slit lamp image, we would just think of doing a full thickness keratoplasty as the details of the AC is not made out. But just doing an ASOCT, we could just find out that the haze, there was not much of stromal haze, all it was epithelium thickness, which was there, which was a hypertrophied epithelium there, the first layer. And just removing of the epithelium on table would increase the visual clarity of the surgery, and then we could just do a lamellar surgery here. So in case of, this is a case of primary graft failure, which came after 1 month. And then on doing an ASOCT, we could find out the graft failure was due to reverse orientation of the lenticule. And then in order to monitor the proper orientation of lenticule, immediate post-op doing an ASOCT would be helpful. As in where you see in the D picture, the endothelium edge should be beyond the stromal edge, and there should be an acute angle, and there should be a smoother edge. This is the picture of a reverse lenticule where the stromal unevenness is seen here. So in case of a chemical, this is a case of chemical injury where there was an acid fall in a 12-year-old boy. What we could see, there was not much of stromal haze, but there was complete loss of epithelium and 360 degrees limbal ischemia. Primary repair of AMG and tarsography BCL was done. So when you have to serially follow up such cases with disintegrating AMG and BCL on, the epithelium is growing or not growing, or whether you have to take up another additional procedure of putting an AMG would be difficult during routine slit lamp examination of fluorescein staining. So in this case, what we could do is, when you just do an ASOCT, you can see here there is a normal epithelium reflex here, and reflectivity here, and the pan is growing here, which is indicating that this is healing, and you need not do any additional procedure. So in keratoconus, after C3R, to see the depth of the demarcation line. So demarcation line, presence of a demarcation line indicates, it's like a surrogate measure to verify that your C3 has worked. And with different protocols, the demarcation line appears at different depths, varying different depths. So in case of refractive surgeries, in order to see or identify the flap to give fitness in any medical legal cases, you can use it. And also in sizing and post-op vault measuring in case of phakic IOLs, you can use ASOCT is of real great help. This was a case where in routine slit lamp examination post IPCL, this AC looked shallower, but on doing ASOCT, there was a good vault height, and then the angle was good, so we could safely do it in another eye.
Dr. Deepthi requesting you, because there's another talk and a session, so
okay,
if you could just wrap up.
Yeah. So this is just in routine cataract surgery where you can use this. This is a case of hazy cornea post-cataract surgery where you can't see DM descemet membrane detachment. On doing an ASOCT, you can just see there is an undulating membrane over here, and putting an A tamponade opposite to that clock arc, it is just going to resolve the descemet's detachment. And then, yeah, it helps in detecting small perforations, and you can just do a routine TA-BCL in case of those things. It also helps in localization of different levels of foreign body in your routine clinic, which you have to remove and which you have to just let go if it is in a deeper stroma where it causes any scarring. In case of removal of foreign body, if there is sufficient depth of stroma you have taken out, you can just do a TA-BCL in clinic. And in case of a deep foreign body where it is penetrated in the AC, you can just, you can't do anything in the slit lamp. You have to take into the OT theater and just remove it. This is just an interesting case of bee sting where the patient came with bee sting injury, and this cornea was so steamy and hazy, nothing could be seen on slit lamp. The foreign body was not detected on slit lamp. On doing an ASOCT, there was a small sting material here, and then he had to be taken into OT, remove the sting, and then additional antibiotics had to be added. If this was not recognized, just putting a topical antibiotics wouldn't have healed the lesion. So I would just say, in summary, the ASOCT acts like in third eye to a routine slit lamp clinical examination. Thank you.
Thanks, Dr. Deepthi. Only one question. What's your experience been on the role in acanthamoeba keratitis?
Yeah, there is some, like, I have not actually used it, but I have gone through few studies which says when there is uveitis, acanthamoeba and herpes uveitis, the ASOCT structure will give us any clue. There'll be those coin-shaped KPs and convexing of your convexing structure in ASOCT in case of herpes simplex, whereas when it is acanthamoeba uveitis, the structure, the convexity of that, convexity of stroma won't be there, and the KPs are very small. They're not that typical coin-shaped KPs. That was only one which I could find, but I have not used routinely this.
Which ASOCT are you using?
Topcon.
Topcon. Great images and good documentation.
Thank you.
Thank you.